So this is the case of a 60-year-old female who presented to the DGH cardiology with an acute case in October 2024. She referred as sudden chest pain with an ischemic sounding, tight, heavy, which radiated to the jaw, to the head, as well as sweating and nausea. It lasted about 2 to 3 hours. And as important medical history, she had been a smoker previously, but was not in the moment of the admission. Also, a medical history of hypercholesterolemia, but no prior cardiac disease. And she had a mother with type 2 diabetes. And interestingly, and I'll discuss this a little more in the next slide, she had an important history of non-functioning bowel, for which she had to have a colectomy done in 1998. So as we can see here, she had an ECG which showed the right bundle branch block, and as well as T-wave inversion in the anterior and inferior leads. Regarding the cardiac biomarkers, she had elevated troponin I and proBNP, also elevated CK and D-dimer, and transthoracic echocardiography was done, which was normal. There was no diastolic dysfunction. Also, the cardiac chambers were normal, and there was no evidence of pulmonary hypertension. So of course, because of the elevated D-dimer, they did a pulmonary angiogram, which ruled out pulmonary embolism. It only showed a small mediastinal or ileal lymphadenopathy. The cardiology team tried to get an MRI, but it was not possible because the patient had suffered from claustrophobia. So they did a myocardial perfusion scan, which showed an ejection fraction of 79% in the left ventricle, as well as a small area of proximal lateral wall distress, inducible ischemia. A CTCA was not performed. So during the admission, she was seen by rheumatology colleagues, and when they were doing the history, the patient mentioned that she had GERD in the last 5 years, also a history of triphasic Raynaud's phenomenon and digital ulcers. In the investigation, she had positive ANA speckled, as well as an anti-Q, anti-SSA, and a borderline rheumatoid factor. Because of the anti-Q, was important, of course, to rule out any muscle involvement. They did also an MRI of the muscle and an EMG, which is normal, and a high-resolution CT scan of the chest, which show a possible mild or early alveolitis. With all of this in mind, as you can guess, the patient was diagnosed as a systemic sclerosis case, fulfilling 2013 classification criteria. She was then started on mycophenolate 2 grams daily and vasodilatory treatment as well. And after already in the rheumatology clinic, the skin had started to progress. The skin fibrosis had progressed to forearms. She continuously presented severe Raynaud's phenomenon and persistently raised troponin I. And then that's when we've got to meet her, when she was referred to our MFT Scleroderma service in August 2025. You can see also that a capillaroscopy was done, and as you can see there, the patient had an active pattern, presence of megacapillaries, hemorrhages, and some dropouts as well. And when we saw her in August 2025, the skin had progressed to a diffuse category. So it was our clinical impression was of a rapidly diffuse scleroderma case with a presumptive systemic sclerosis myocarditis with no other clear basis for persistent elevated troponin I and anti-proBNP. We ordered an FDG PET with rubidium 82, as well as Holter monitor, and referred her to our cardio-rheumatology MDT. Here in the PET scan, you can see you have that. Yeah, I'm not sure if you can see that the quality probably is not that good, but the patient has an increased uptake in the mid-basolateral left ventricle myocardium, which extends inferiorly, and a mild septal uptake, which is compatible with active cardiac inflammation. There was also an heterogeneous colonic uptake, which was deemed to be physiological, and a mild splenomegaly. So this is the case overview. The first thing is that history of in 1998 of a non-functioning bowel. Why is this relevant? Because more than 50% of patients with systemic sclerosis can have GI involvement and GI manifestations. It's very typical that this motility in these patients, which sometimes can lead to pseudo-obstruction. Then these patients started in 2020 with her GERD and Raynaud's phenomenon, and after that, we don't know specifically when, she started developing digital ulcers. She then presented with her cardiac symptoms and raised troponin in October 2024, and she was diagnosed as a systemic sclerosis case in December 2024, for which she started receiving mycophenolate. When we saw her in August 2025, the skin had continuously progressed, and the PET confirmed a diagnosis of inflammatory myocardiopathy. So, as a summary, this patient is a case of a systemic sclerosis patient with severe Raynaud's phenomenon, GERD, the rapidly progressive skin involvement to a diffuse involvement, and a primary systemic sclerosis myocarditis and onset, as well as a possible early ILD. We had a discussion in our cardiac rheumatology MDT, and we decided to initiate pulse cyclophosphamide as well as a modest methylprednisolone dose. We considered rituximab at some point, but it was not available for this patient specifically. And from the cardiovascular point of view, we started her on aspirin and also given her a trial of SLG2 inhibitor and plan to have another PET in the next 6 months. So just a brief overview for our colleagues who are not rheumatologists. Systemic sclerosis is a systemic autoimmune disease with multi-organ involvement. It associates high morbidity and mortality. It can reach 50% at 5 years, and it is very heterogeneous, whether the presentation, the serologic or the autoantibody profile, as well as the organ involvement. There is a fourfold increased risk of cardiovascular involvement in systemic sclerosis, and almost 25% of the deaths are due to cardiac causes. It's even found in autopsies where myocardial fibrosis or inflammation can occur in 80% of the patients. So primary heart involvement, although frequent, is very underdiagnosed and sometimes even subclinical, like we heard in the previous talk. There was also a lack of standardized definition until very recently, and most of the studies we have are confounded. There are patients included who have pulmonary hypertension, renal crisis, hypertension or diabetes, and it was just a couple of years ago that the WSF, the World Scleroderma Foundation, published the systemic sclerosis primary heart involvement definition, which includes cardiac abnormalities who are attributable to systemic sclerosis. So they cannot be explained by ischemic heart disease or other causes of cardiomyopathy or even secondary myocardial effects. So, of course, following initial TTE, which in systemic sclerosis, it's very important because we need to rule out pulmonary hypertension, cardiac MRI is the main imaging modality to diagnose myocarditis, and the PET can be used also to track inflammation. However, we don't know, there is no evidence-based treatment guidelines. There are studies, observational studies, and case series that mention the use of mycophenolate, cyclophosphamide, and rituximab, which is why we need larger longitudinal multicenter studies with harmonized imaging protocols. And just a mention on our case, so traditionally, systemic sclerosis starts with the skin, the Raynaud's phenomenon, then it can go with the skin thickening, and then the major organ involvement, lungs, kidney, heart. But there is more and more evidence that shows that for some patients, this can even be the first manifestation, which can occur before or at the same time as the skin or vascular symptoms are evident. So as learning points from this case, it will be to recognize the myocardial injury as a potential early and primary manifestation of systemic sclerosis, evaluate the role of advanced imaging. In cases where CMR is not possible, consider a PET in detecting regional myocardial inflammation in patients even without overt autoimmune features. And last but not least, to discuss the wider clinical presentation and treatment options that can be considered in this case and all systemic sclerosis cases. And that's all from my part. Thank you very much, and I'm happy to answer any question you might have.
Thank you very much. A really good case, and I think really reflective of clinical challenges that we face quite often. So I have two questions about the cardiac management. The first one, if I remember rightly, the patient had a PET perfusion scan initially a year or two ago that showed a lateral wall perfusion defect. Was that followed on? Because that would suggest coronary artery disease rather than inflammatory disease.
She had a...
So just to clarify, no. So the perfusion scan, because it was done to exclude coronary artery disease because of the presentation, it was done in October at time of admission.
Okay.
And we're still getting those scan results and trying to review it, but the radiologist that reported wasn't convinced of inducible ischemia, which is why I think you've put borderline small area of lateral walls. So the sense was on presentation, this was an ischemic presentation. They didn't do angio, interestingly.
That was my question, was it on CTC?
No, we've gone back,
something else going on.
Absolutely. So the presentation was very unusual for scleroderma myocarditis with the kind of chest symptoms, chest pain symptoms. So I'm not quite sure why an angio wasn't done, or even a CTCA at some point, but they've gone on the myocardial perfusion scan. And then subsequently, she's had a asymptomatic but chronic troponin rise.
Okay. Yeah. Thank you. That was my first question. The second was I applaud the cardiac medications that the patient is on, because that's not common. So many of these patients have cardiac manifestations, and they don't get any cardiac drugs. And there's a comment on the on the chat actually here from, again, Dr. Davies. With SEC, I often find the focus on pulmonary hypertension ignores the heart muscle and pericardium. More studies are needed. Yeah. So your patient ended up on aspirin and an SGLT2 inhibitor. And I don't know if you know, but can you elaborate on the rationale for the SGLT2 inhibitor specifically?
Yeah, so I think that's the advantage of the cardiac rheumatology MDT. So because she had the left ventricle changes, that was the reason why we decided on starting her on the SGLT2 inhibitor. But you're absolutely right. I think systemic sclerosis and in other conditions, I don't think a lot of people are under SGLT2 inhibitors for sure.
Because the cardiology indications are in patients with either heart failure, systolic heart failure, or diastolic heart failure, or HFpEF as we now call it, when it's symptomatic. But as an additional agent, normally to a diuretic or something else. I mean, I applaud the use of SGLT2. I think it's a great drug in this context. But I was just curious what what motivated you to give it.
It was purely in the context of saying there is clear-cut inflammatory cardiomyopathy here. It doesn't fit with NICE guidance, like you say, in terms of HFpEF or renal disease, etc. There may be some additional utility of this in this context, but it is evidence-free area, totally.
But evidence-free, but probably pretty much the right thing to do.
Too.
Any other question? Let's see if there's anything in the chat.
A question, if I may. You mentioned that you used PET-CT to monitor treatment response. Do we have the same problem as Jason got reference to with regards to you'll still get some activity with LVV, you still get some PET-CT activity, even though there's disease remission. Do you get the same in this scenario?
Yeah, so we haven't. So we're because we just met her in August and just started the treatment. So we plan to have it in 6 months. You're absolutely right. So we need to see. I think the answer that was given this morning was also very important. If the patient also, I think we don't know what these therapies will do to the heart, and I think if we have the patient under this specific treatment, so it's cyclophosphamide and possibly then mycophenolate, I would say if the patient is remission, I don't think it's a word that we can use in systemic sclerosis, but if the disease activity is controlled, personally, I think I would not switch the treatment of this patient, but I leave that question to Maya, because I don't think we know enough to to just switch just off a PET.
Switch to, sorry, I missed that. Switch to a.
If there is continuous inflammation. Sorry.
It was probably more directed towards Ben and Jason. It's actually, will there still be some PET-CT activity despite disease remission, like you mentioned in LVV in this scenario?
Yeah, it could be, but I don't think.
Yeah.
I mean, I don't know specifically in scleroderma, but I imagine that if you still have like myofibroblast proliferation, that you would still have some FTG signal.
There is a nice case report I sometimes show when I talk about cardiac imaging more general, where there is PETs, a lot of inflammation that with treatment reduces. So I think you would think intuitively it should get better whether it goes back to completely normal.
Yeah,
I don't know.
I think the patient would, despite I think the follow-up CT, she would receive the cyclophosphamide, and possibly then we'll have her start on continue the mycophenolate. But I think that even if there is active inflammation, the problem is I really don't know, other than pulsing her or giving her steroids, which in this case in systemic sclerosis for renal crisis, it's always tricky. What else can we do in this case? I think that's the ultimate question here.
There's a related question on the online audience. How many patients with silent heart inflammation are we missing because we wait for skin changes before thinking of systemic sclerosis, and that sort of goes in the same direction? I think I showed some data on that. When you use T2 mapping, about half of patients with systemic sclerosis have MRI evidence of inflammation. So it is extremely common. What we don't know is, as I said in my presentation, how that responds to treatment. Which treatments we don't tend to monitor, like most centers. I think we do an MRI scan once, and then we don't do it every 6 months. I'm not sure we could afford to do that as a health service. But yeah, a lot of open questions. But my sense is that in many patients they have chronic background inflammation that you can pick up with sensitive methods in the heart, and we should probably aim to suppress that as much as possible, both with systemic drugs that you give for systemic sclerosis, but also with cardiac specific therapy, which these patients largely are not getting.
And I know often when I see patients who have a fixed elevated troponin, particularly in the context of autoimmune disease, one of the things, if it's a troponin I, one of the things I consider is whether or not it's an assay issue with a macrotroponemia. And I wondered what people have had the experience of sending a paired TROP-T with their TROP-I in these cases. And if this was done.
So in Manchester, where we work, we have to send off paired because our local hospital does TROP-T, and then we send off a paired TROP-I. So it provides some element of validation. In this lady's case, it's got better. It's still chronically raised. Yeah. I just wanted to add the point for scleroderma, and to Sven's point, in terms of treatment, so about half have some abnormal CMR. And when I worked with Sven from the Leeds cohort, they were an asymptomatic cohort, scleroderma cohort. Obviously, in scleroderma, we'll treat with immunosuppression anyway, in the absence of cardiac involvement, if they are in a diffuse category, to mitigate potential organ involvement, and definitely if there's skin involvement. So the skin involvement to us was a danger sign. Within 3-4 months, her skin was already progressing. So that already was a poor prognostic indicator for lung, for heart, for kidney. So we'd be treating anyway. I think it's the kind of immunosuppression, whether you escalate to cyclo or other, that's where then the presentation and the context becomes really important, because all these patients will be on mycophenolates, at least the scleroderma patients.
Yeah, but your choice of drug is not guided by the cardiac.
No,
and the diffuse, the rapidly progressive aspect of it, I think
it is by other organ involvement. But if they had, I don't know, if they had other arrhythmogenic disturbance, if that cardiac involvement was felt to be clinically overt, then I'd be pulsing them, and that's why in this patient, her presentation, etc., was concerning, etc. Yeah.
So in this case, I guess you chose cyclophosphamide mainly because of the rapidly progressive skin disease. Otherwise, you'd probably have gone for something
You
less.
stick with mycophenolate. It's early lung and heart and with rapid skin. Yeah.
Okay. No, that makes sense. And that, no. She was only KU positive and anti-ROLA positive, right? She didn't have.
Yes,
Okay.
he didn't have centromere or anti-SL70.
Okay.
No. But seeing the overview, of course, you have that sudden cardiac symptoms, but even before that, there was little things that when you assess it all, it all makes sense.
So I can imagine that at the early stage, the diagnosis was not easy to make. Yeah.
A few more comments, no questions on the chat, but generally for the benefit of others in the audience, underscoring the fact that often these patients are underdiagnosed, discharged, and perhaps not enough emphasis is given to the to assessing cardiovascular involvement.